Okay, good morning everybody. Thanks very much for coming to the John Snow Scholarship presentations. My name's Dona and I've got the pleasure of chairing this session, and we have 5 presentations for you today. Probably without any further faffing around, I think I'll ask our first speaker to come up, and this is Dr. Rebecca Chan. So Rebecca recently completed her medical degree at the University of Notre Dame, Sydney, where she developed a keen interest in public health medicine. She's recently started her internship at Nepean Hospital and is hoping to undertake a career in general practice with a focus on public health research. So over to you, Rebecca.
Thank you. So my presentation is on the health behaviours in people with intellectual disability and co-occurring type 2 diabetes.
Can I suggest a little more volume?
Yep. Better? Okay. So approximately 3% of the Australian population has an intellectual disability, which is characterised by significant limitations in both intellectual functioning and in adaptive behaviour. This population also has a higher risk for developing chronic diseases than the general population, for example, diabetes. So in 2003, diabetes was responsible for 5.5% of the total burden of disease in Australia. And by 2023, it is projected to be the leading cause of burden of disease for men in Australia. Patient self-management has been found to be crucial in decreasing the incidence of complications. However, currently there is no research about the self-management of people with both intellectual disability and co-occurring diabetes. So the aim of my project was to describe the health behaviours of people with intellectual disability and diabetes by assessing the frequency of their adherence to recommended guidelines. So my project was part of a larger study called the Living with Diabetes study conducted in Queensland. So for this study, cross-sectional data from a postal survey of about 3,000 individuals in Queensland was used. Participants were recruited through Australia's National Diabetes Service Scheme, and 3 locations of policy interest were oversampled: an outer metropolitan area, a new suburban development, and a coastal agricultural community. A person was defined as having an intellectual disability if they answered yes to the question, "Have you ever been assessed as having an intellectual disability or impairment?" 4 main health behaviours were assessed. These were nutrition, physical activity, smoking and alcohol intake. And adherence was defined as meeting guidelines set out in the Diabetes Management in General Practice report. So for nutrition, this included 2 serves of fruit and 5 serves of vegetables a day. Physical activity was greater than 150 minutes of moderate intensity physical activity per week, for example, walking, and this accounted for about 30 minutes for at least 5 days of the week. Being a non-smoker, and alcohol use no more than 2 standard drinks per day. So the response rate for the Living with Diabetes study was 29%, which is about 3,000 respondents from the 14,000 asked to participate. And of the participants who responded, approximately 1.9% reported having an intellectual disability. So the frequency of their adherence to recommended guidelines can be seen in this table. So there was quite a low level of adherence to recommended guidelines for the nutrition and physical activity. However, quite a high proportion of this population were found to meet guidelines for smoking and alcohol intake. In comparing this population of people who had both intellectual disability and diabetes to the rest of the study population who had diabetes alone, we found that people with intellectual disability were significantly more likely to be sedentary and to be obese or morbidly obese. They were, however, also significantly more likely to be non-drinkers. We then went on to compare these results to what has previously been shown in the literature, looking at populations of people with intellectual disability alone. So we found that people who had intellectual disability and diabetes had similar levels of alcohol use and smoking status as studies of people with intellectual disability alone. They did, however, were more likely to adhere to recommended amounts of fruit and vegetable intake compared to people with intellectual disability alone. So you may remember previously I showed that only 15% of our population adhered to recommended guidelines. However, this was still higher than what had previously been reported in the literature. And we put this down to perhaps that research has shown people who are diagnosed with diabetes may follow a changed eating pattern, and people who have an intellectual disability may have such a changed eating pattern imposed upon them by their carers or in institutions such as in hospital where you can be given a diabetic diet. Nevertheless, 85% were still found to be consuming less than the recommended intake. There was also a much higher incidence of sedentary lifestyle for people with intellectual disability and diabetes. So for sedentary lifestyle, these people reported having no leisure time physical activity at all. So in our study, we found that 31% of people with intellectual disability and co-occurring diabetes had a sedentary lifestyle and reported no leisure time physical activity. This was compared to only 10% of people with diabetes alone in our study, and approximately 13 to 16% of people with intellectual disability alone, as previously reported in the literature. So the implications of this research is that there is a unique health profile for the population of people with intellectual disability and co-occurring diabetes, and it may be that health interventions need to be developed which specifically target this group. So moving on to the reflection part of my presentation. So I was reflecting on this competency, which was to promote a population health approach within the health and disability care sector. And there were two factors which I felt were important in deepening my understanding of this competency. So the first was in being able to define the population. So in order to develop a population health approach for a particular group, there must first be an understanding about what health inequalities exist. And this has basically been the basis for what my project was about. Because unless we know what gaps there are, we can't actually do anything to improve the services which are available. I found this particularly relevant to my project as when we did a literature review prior to starting the project, we found that no other study had previously looked specifically at this population of people who had both diabetes and intellectual disability. Currently, there's only one website available on the internet which provides educational information on diabetes for people with intellectual disability and their family. And I've just put some, so this website's called Diabetes to the Point, and I've just put some examples of what the website shows, which is giving basic information in simple language with pictures to allow these people to get the necessary information they need to lead healthy lives. So this website was actually developed by the same group who I did my project with in a response to research that they had done, which showed that people with diabetes often felt limited by their disease and their families often felt they had inadequate knowledge to provide support because they didn't have enough information about the topic to be able to make informed decisions and choices. So this leads on to the second part of my reflection, which is the role of advocacy in public health. So population health approaches will only be successful if there is appropriate advocacy in place in order to promote these issues to the wider public. So in doing this project, I started to reflect on and realise that as researchers, it is our duty to facilitate this, and this was demonstrated to me quite clearly during the course of my project. So through my experience, I came to realise just how involved the group that I was working with were involved in people with intellectual disability, not just through their research and clinical services, but also through their interactions with various politicians and their input into national guidelines and recommendations. So without this sort of advocacy for the populations that we're trying to support, the research that we do may never actually be translated into policy or practice and will therefore have very little impact onto the health of that population. So then in addition to developing my understanding of that particular competency, overall, during the course of this research, I came to realise just how well integrated public health research can be with clinical services. So I've always thought that despite my interest in public health, my desire to undertake clinical work would prevent me from going too far into this area of medicine. However, my experience has shown that it's entirely possible to combine the two domains into one career. My project was supervised by clinicians who were involved in both research and clinical work, and I was able to sit in with them on some of their clinics, which helped to give me a better understanding about the context of my project. In addition, coincidentally, shortly after completing my project, I went on to complete a general practice rotation where a GP attended a home for men with intellectual disability once a week to provide necessary medical attention and checkups. And I found that the knowledge that I had gained through doing this research gave me a greater sense of empathy with these patients and also helped me to better understand the course of their medical conditions. So overall, I found that undertaking my project was extremely rewarding. I was not only able to learn how to conduct a research project, but also gain a better understanding of public health and how it can contribute to medical practice. Thank you.
Perfect timing too.
Oh, good.
Any questions? Yes, Charles.
What do you think are the main differences in intervention for diabetes in people with and without intellectual disability?
Well, I guess ensuring that the population of people who have diabetes and intellectual disability are actually able to access those interventions and that their families are able to support them in undertaking those interventions. So a lot of people with intellectual disability, I think often their medical conditions aren't as well, are sometimes not as well looked after because there's people, so they're not as well known as other people. You know, they might not go to try and access the intervention. If they do, they might not have as well an understanding as people who don't have an intellectual disability. And so they might need more support to ensure that they can actually, you know, it's the right sort of intervention for them. It may be too complex for them to understand, or it may be that they can't actually get there, different things like that.
Thank you. When intellectual disability is non-homogeneous,
Yeah.
did you find yourself categorising types of intellectual disability in relation to your study?
So unfortunately in our study we weren't actually able to determine the level of intellectual disability as it was part of a larger study, and we based the inclusion into the study on whether or not they answered yes to the questionnaire for if they had an intellectual disability or not. Based on the demographics of the population, a few of them were married, many of them had education or higher education. We determined that they were probably of a milder level of intellectual disability and not so much, you know, a higher end of the spectrum. So we weren't actually able to infer in the study whether or not the level of intellectual disability would have impacted the results, and it's probably, I think, a study which would be important to do in the future, as we weren't able to do that through ours.
Thank you very much for your presentation. I've got more of a technical question. You did some comparisons within the study that you're looking at, and then you actually did some comparisons of people with intellectual disability to external data sets.
Yeah.
Could you please comment on the potential biases that might have resulted from that, and when you were saying that one proportion was higher or lower than the other?
Yeah, so we did comment, and it was mostly based on just the results from the literature. We didn't do any like statistical analysis of other data sets. So I guess in determining the limitations from our study, we had limitations based on what the population we had were, in that we weren't able to determine what level of intellectual disability they had. Whereas other studies looking at populations of people with just intellectual disability, their study populations and their results were probably, like, they were better able to determine, you know, levels of intellectual disability in their studies where we weren't in ours. So that probably would have affected the comparison as well. But again, in the fact that there is no other study which has looked at this specific population, I guess we kind of felt we had to start from somewhere with this population, even though it would be better to have studies which, you know, were better aimed at that specific population.
Any other questions? I've got a question.
Yeah.
You said that there was a 29% response rate. That was overall.
Yes.
Yeah. Do you know what the difference in response rate was between the people with intellectual disabilities and those without?
No, we don't. Because we only knew the population of people who had intellectual disability once they returned the questionnaire and had answered yes or no to that particular question.
Did the people with intellectual disability fill out their own questionnaire?
That was another limitation of the study which we felt could have impacted some of the results, as we weren't able to determine whether or not it was filled out by those participants or whether it was filled out by someone for them.
Okay. Right. Thank you very much, Rebecca.
Thank you.
Our next scholarship recipient is Miss Johanna Warren. Jo is a fifth-year medical student at the University of Adelaide. She's a recipient of the Rural Australian Medical Undergraduate Scholarship. I think that's RAMUS, isn't it?
That's the one,
yes,
yeah.
which is a bit easier for me to say, and is based in Port Lincoln and Ceduna for the rest of her medical studies. Jo's also currently undertaking a Masters of Public Health externally through Flinders University. It's a wonder you've got time to scratch yourself. Okay, so welcome, and we'll look forward to your presentation.
Thank you, and thank you to the college for the wonderful opportunity to speak today. So I'll be discussing recreational use of the drug dimethyltryptamine, or DMT, within Australia. And I'll begin by providing some background information on what DMT actually is, and then I'll follow this by a case study and provide an overview of a literature review that I undertook, followed by a reflection on the public health competencies that I developed during this research process. So what actually is DMT? Well, it's short for N,N-dimethyltryptamine, which is a chemical substance that's present in the human body. And its mechanism of action is thought to be as an agonist of serotonin receptors in the central nervous system. And DMT may also be taken exogenously as a recreational drug with hallucinogenic effects, usually smoked. Interestingly, DMT is also present in quite high concentrations in many native Australian plant species, particularly acacias. We've got some examples of particular acacias with high potencies. So many of you may well have these plants growing in your backyards. So my interest in this little-known subject was sparked by a patient that I came across in 2012 as a medical student on a psychiatry rotation. And the patient was a 24-year-old man from rural South Australia who presented for the first time with features of psychosis after experimenting with DMT over the preceding 6 months. And the patient had been grinding up the bark and leaves of DMT-containing plants and adding this to his cannabis pipe. And he planned to start extracting DMT, a pure DMT, from plant matter using chemicals based on techniques he'd found on the internet. And I was quite alarmed by this and identified 3 really worrying health issues for this patient. One, that the DMT use could have contributed to him developing schizophrenia. Secondly, the presence of hydrogen cyanide in many natural plant species and the risk of accidental ingestion. And thirdly, the hazards of the chemical extraction process that he described. So I was interested to find out more and decided to undertake a literature review. So the aim of my review was firstly to look at the epidemiology as well as the health risks and the public health response to recreational DMT use in Australia. So 2 general methods underpinned my research. Firstly, I undertook a literature review, which involved a systematic search using electronic search engines followed by critical analysis. And secondly, I used the National Drug Strategy 2010 to 15 to consider how the public health community in Australia could go about controlling recreational use of DMT. And from the systematic search, I was only able to identify 15 publications that met my inclusion criteria. And only 1 article has ever explored the epidemiology of DMT use in Australia. Because of the limited peer-reviewed information, I then decided to expand my search to also explore the grey literature, including popular media sources, interviews with DMT users, internet forums, and even some horticultural reports. And according to the literature, the main population subgroup using this drug in Australia are, unsurprisingly, the users of other drugs, particularly cannabis and non-DMT hallucinogens. And the prevalence of use does seem to be rising. So here's a recent example of public interest in DMT. This is an advertisement for a screening of the film The Spirit Molecule, which was released in 2010 at the Byron Bay Community Centre. And the book version, which I've got here, was published originally in 2001. And the book and film portrayed DMT as this sort of a spiritually significant substance, and that use of it is this philosophical, life-changing experience. And the grey literature suggests that this book and film may be contributing to the rising prevalence. So although there's no published information on just how many people what prevalence of use there is in Australia, here are a few indicators of the significance of this problem. Firstly, typing DMT extraction into a Google search engine produces over 428,000 search results. And some of you may know the film rating website IMDb, and that has over 1,300 ratings for the film The Spirit Molecule, which is also available on iTunes. And here's a graph of the rising trend in Google searches for the phrase, the spirit molecule. And that's back since 2004. And here are the global origins of those Google searches, and you can see Australia quite strongly highlighted there. So now my findings on the 3 health risks that I was concerned about earlier. So in the context of the patient on the ward, I began looking for an association in the literature between DMT and schizophrenia. And I discovered that there are established theories that high levels of DMT in the brain can contribute to the development of schizophrenia, although there's not really enough evidence to establish the direction of the relationship or the temporality. However, most of the research in this area was conducted in between the 1950s and 70s, and the link requires extensive further exploration using modern technology. Secondly, I found that several acacia species that are being used for DMT extraction on internet forums do indeed contain toxic doses of cyanide that could be ingested by users. For example, Acacia obtusifolia has been implicated in livestock deaths because of its cyanide content. And thirdly, on reading some of the online DMT extraction guides, I was quite shocked by some of the obvious hazards involved, such as handling really volatile acids and heating highly flammable solvents. So now my findings on what we could do to prevent DMT use. And the National Drug Strategy recommends a 3-pillared approach to minimising the harm from any drug at a population level. And the first pillar is supply reduction. Now obviously it's going to be difficult to reduce supply of DMT in Australia because it's present in so many plants all around us. It's even worse than cannabis because it's in so many different species. However, a 2011 discussion paper by the Attorney General's Department in 2011 did actually propose that any plant containing DMT be listed as a controlled plant, which would mean that it would be a serious drug offence to cultivate or sell any plant containing DMT. So that includes all those acacias and things I mentioned. So they obviously recognise that this is a major, becoming a major issue. The proposal provoked outcry from nurseries and gardening societies, which was widely publicised in the media. So this illustrated to me the flow-on effects that public health policies can have on a lot of different population groups, and banning the hundreds of native plant species doesn't really seem to me like a viable option. So the second pillar is harm reduction, aiming to minimise the adverse consequences of use of the drug once they've already occurred. But I think we'd all agree that it's generally better to prevent illness from occurring than to treat established disease, particularly when dealing with a chronic problem like schizophrenia. So I moved on to the third pillar, which is demand reduction, and I think this is where the money is. I think this would be the most realistic and effective option. So I propose a 3-step approach to reducing demand for DMT. One, we need to properly measure how many people are using DMT in Australia and who they are. And for example, DMT could be added into the National Drug Strategy Household Survey next time. Secondly, we need research that clearly defines the health risks of this drug and whether there is a genuine link between DMT and schizophrenia. And thirdly, once we have this solid evidence base, we can attempt to reduce the demand for DMT by educating current or likely future users on all those health risks. And this small population subgroup could be targeted through, for example, drug and alcohol centres or even GP clinics. So here are some So here are some take-home messages about recreational DMT use in Australia. It seems to be on the rise, particularly among users of other illicit drugs. And health risks may include schizophrenia, cyanide toxicity, contamination or chemical injury during extraction. And on the whole, preventing DMT use is going to be preferable to treating its health complications. And in order to do this, a demand reduction strategy is recommended. So by undertaking this project, I've developed skills in identifying a clinical question, I'm undertaking a narrative literature review, and also plan a critical analysis and analysing levels of evidence. What I hadn't learnt in the past from the textbooks is how important it can be to take the grey literature into account in new fields of research. Some of the most useful insights that I gained were not from the peer-reviewed journal articles, but from that grey literature. And doing some detective work and exploring these resources is needed at the start of the chain that then directs more formal structured research. The second objective that I improved my skills in was advocating for action to respond to public health problems. After writing my report, I presented this topic at a unit meeting at the psychiatry hospital at which I was based, and the concerned and interested response from the psychiatrist prompted me to submit an article to the Australian-New Zealand Journal of Psychiatry, which got published in April. And by presenting it at this conference and other conferences, perhaps at the College of Psychiatrists conference, I hope to spread awareness of rising DMT use and its risks. And my ultimate aim is to stimulate and perhaps personally carry out further research in this area. So on the whole, I've learnt about the importance of advocacy and how it can stimulate interest and research, which then provides that evidence base for good public health policy. And because of social media in the modern age, unfortunately public health problems like this can be a lot more difficult to solve than simply taking the handle off the pump back in the era of Jon Snow. So thanks for listening to my presentation. Are there any questions at all? Yeah, Ben? Oh.
Reducing demand of this substance is probably the best way of going forward with a public health intervention kind of thing.
Sure, yeah.
I'd never heard of DMT before.
Yeah.
I think that raising awareness of this substance might actually have some unintended consequences, particularly informing the public about the availability of another substance in household plants.
Yeah, I have thought about that. And that's why I think it would be more appropriate to do quite a targeted education strategy aimed at those people who are already using the drug. And I think there's a lot of people that we don't realise that are actually or know about or using the drug already, and sort of try and redirect them. Or the people who are using cannabis or LSD or things like that, who undoubtedly would have already heard of it before from their groups, and just spread awareness of the health risks, just so that they've got, because at the moment it doesn't seem, even on the internet forums and things, there's not really any mention of any possible health risks. So maybe just having that knowledge there would be enough to deter some people who would otherwise not think about it. Yeah, thanks.
Thanks for that. You said that the DMT use was being used by your 24-year-old by grinding it up and adding it to his cannabis product.
Yep.
And that between 97 and 98% of users had used either cannabis or LSD as well. And I'm wondering, first of all, clinically, how do we know that DMT itself was actually contributing to the psychosis and not the concurrent cannabis or LSD use?
Mm-hmm.
And the second thing is, would it be, in your view, better value for money to actually target cannabis users because of, as you suggested, they may also be using DMT rather than DMT users alone?
Sure. Yeah, thanks for that. It's a good question, both of them. So for the first component about the use of other drugs, that's what the problem that I have with the patient as well. There's so many confounding factors that obviously in this patient you can't simply say that this is the causative factor of his psychosis. It was more as an illustration of how my thought pattern developed, but. I think, that's why I think it would be really difficult in these patients to ever say that was the cause, because it'd be so unlikely that they weren't using cannabis or something else. I'm sort of quite interested in there being more research into the role of DMT in the brain as in the pathogenesis of schizophrenia, and so not so much as being able to point to people and say that this psychosis was caused by DMT, therefore if you stop using it, it will, that's not schizophrenia, but that would be a drug-induced psychosis. But so more using, taking the knowledge that we've gained and seeing whether it contributes to the understanding of the etiology of schizophrenia and therefore medications that could be used. Because when we got to about 1970, I think in the US there was quite a lot of research in this area, and then DMT and LSD and things became illegal even in research, and that sort of stopped a lot of the research into this field, which has never really been picked up as it was. So it would be an interesting area to study. Yeah, thanks.
I suppose the follow-on from that would be, I don't think you mentioned it, the actual current legal status of DMT in Australia, and therefore follow-on from that.
Yeah, sure. Well, it's listed as a Schedule 9 drug, so it's prohibited in Australia except for the purposes of research, which is the same as for LSD or MDMA, things like that. So, it's listed as illegal. And I think that was since, that's been sort of for a couple of decades. So.
I think was there another question up the back? Yes. Yeah.
I think you've told us very nicely how you've moved from a clinical observation into looking at a population health issue. And I'm just wondering now, having done that, how you see going back into a clinical environment, that population health knowledge will change some of your approach to clinical practice.
Yep, absolutely. So I think from a simplistic point of view, I think I would, in this kind of population, I would always now be aware of asking about use of that drug, and hopefully educating the patients that there is this unknown about whether use could contribute to schizophrenia, particularly because it causes this sort of schizophrenia-like state, and whether that could cause chemical, permanent chemical changes in the brain. And so in terms of just explaining the health risks and trying to get other people to do the same if people have heard of this drug and have been using it. And secondly, I think we could probably apply some of the principles to use of other drugs, and just always being aware of asking the patients about whether they're using hallucinogens and whether they've ever considered the health effects, and also just that the spread of knowledge, just understanding if we could all find out the epidemiological patterns just by talking to patients as well, and how it spreads. But clinically, and ideally there would be a new wonder drug or something that inhibited schizophrenia in the brain that could be used clinically to make progress in that difficult field.
Okay, there's no more questions. Thank you very much.
Okay, thank you.
I'd like now to ask Mr. Ben Lazarus to come and give his presentation. Benjamin Lazarus is a final year medical student from the University of Queensland in Brisbane. He's currently undertaking an honours project at the UQ Centre for Clinical Research that's looking at animals and meat as a source of resistant bacterial infections for humans.
Okay, so just a question, to use this one, I just press the forward button, is that the one on the right?
How did you,
Yeah, okay, cool. So good morning, everyone. My presentation for the John Snow Scholarship will consist of two parts. Firstly, I'll summarise my research project, so what I actually did, and then I'll reflect on how doing this project has enabled me to better understand two specific learning objectives that have been published by the Australasian Faculty of Public Health Medicine. So last year, I submitted a systematic review to the School of Medicine for my honours thesis, which is trying to answer this question. Are food-producing animals a source of third-generation cephalosporin-resistant E. coli infections in humans? Third-generation cephalosporin-resistant, or 3GCR E. coli infections are a big problem. Not only are they rapidly becoming more common, but they're also associated with higher mortality, longer hospital stays, and higher healthcare costs. Drug companies are also quite reluctant to develop new antibiotics because they don't really offer a good financial return. Bacterial infections don't usually last for a very long period of time, and also they have this annoying ability to develop resistance, which would render all these new medications ineffective. So as a result, there's been a lot of attention that's been given to trying to prevent these resistant infections from occurring in the first place. And to do that, we kind of need to know where are these resistant bacteria coming from. So we wanted to find out whether food-producing animals are a source. There's been a lot of studies showing that antibiotic use in food-producing animals can promote the development of resistant bacteria, including 3GCR E. coli. But whether these resistant bacteria are actually able to be transmitted to humans via the food chain is not as clear. So at a molecular level, there are really only two ways that this transmission can occur. You can either have a resistant animal bacterium that gets physically transmitted as a whole bacterium to cause a human infection. We call this whole bacterium transmission. Or you can have a resistant animal bacterium that donates its resistance genes to another bacterium, and that other bacterium is the one that causes the human infection. And we call this mobile genetic element, or MGE, mediated transmission. By comparing the genetic similarity between animal and human bacteria, we're able to estimate basically how likely it is that they've been transmitted between both of these sources, and we can also determine which mechanism of transmission is being used. So for this study, we followed the PRISMA guidelines, which is an internationally accepted protocol for conducting and reporting systematic reviews. Our search included PubMed, Medline, Embase, and the Cochrane database of systematic reviews, and we used the search strategies that are shown here. And it all looks a little bit complicated, but basically the search is based on 3 key terms. Firstly, to denote the relevant bacteria. Secondly, to denote the relevant food-producing animal or meat. And finally, the resistance element itself. I can discuss this in more detail if you want later on. So the resulting 2,111 abstracts were independently reviewed by myself and another researcher. 73 full papers were selected and 25 were included in the study. We found 6 articles that supported the hypothesis of whole bacterium transmission, all of which suggesting poultry as the primary food animal source. 3 Dutch studies, in particular, found high-quality evidence, with temporally matched and clonally related isolates being identified from all levels of the food chain. So basically in the animals, so the chickens, the retail meat, and in the human infections. And the remaining 3 studies, which were 2 in Spain and 1 in the US, they only found a relatively small number of matching isolates, and there were also some methodological limitations with both of these studies. We found 12 publications that support MGE-mediated transmission, and the most striking feature about this form of transmission is the diverse range of settings in which it can occur. These studies were conducted in Western Europe, North America, and Asia, and poultry, pigs, and cattle were all implicated as sources of transmission in each of these regions. So basically, there is evidence that both forms of transmission may play a role in the burden of resistant E. coli infections in humans. Okay, so when I first asked myself, what are the public health implications of this research, my first impulse was to jump straight to an intervention and basically advocate for the cessation of routine antimicrobial use in food-producing animals. But over time, I've come to realize that a public health physician would approach this problem in a very different way. First of all, before jumping straight to an intervention, it's important to realize that more information and research is required for this issue. For instance, from our systematic search, we didn't actually find any studies that were conducted in Australia. And even in the Netherlands, where there were some high-quality studies, it's still difficult to quantify the burden of human disease that is attributable to animal-associated bacteria. We should also try and find out a little bit more about how bacteria in animals are specifically able to get transmitted to humans, and what are the kind of underlying factors that enable this transmission. And this review was also limited just to 3rd-generation cephalosporin resistance, and so it's entirely possible that other forms of resistance are equally important. So despite the fact that more information and research is required, I still believe that we should think about how to approach this issue from a public health perspective. The first step in dealing with a multi-sectoral issue such as this would be to identify and involve the relevant stakeholders. In Australia, this would include community organisations such as the National Farmers Federation, the Australian Veterinary Association, the Australian Meat Industry Council, consumers and clinicians, as well as government agencies, particularly the Division of Food Regulation and Safety within the Department of Agriculture, Fisheries and Forestry, the Food Regulation Program within the Department of Health and Ageing, Food Standards Australia and New Zealand, and state governments, who are actually the ones who are in charge of enforcing these national food standards. In Queensland, this would include Safe Food Production Queensland and the Department of Food Safety Standards and Regulation within Queensland Health. But obviously it would vary depending on the state. I've also realized that instead of suggesting a specific kind of intervention, a more comprehensive approach would be to analyze the options that are available. In this project, there are kind of two key targets for intervention, which can be classified as either preventing the emergence and spread of resistant bacteria in animals in the first place, and secondly, once the bacteria are there, preventing their transmission to humans. The first target can be addressed in three main ways, which are to reduce the antibiotic use, that's really the driving force behind the selection of these resistant organisms, preventing dissemination of resistant organisms between animals, so basically limiting the number of animals that contain these resistant bacteria, and to maintain ongoing surveillance and monitoring for resistant organisms so that we can apply an intervention at an earlier stage. In terms of preventing transmission to humans, I think at this stage it's still quite difficult to develop an effective strategy because we just don't know enough about the mechanism by which humans acquire the resistant bacteria. It's possible that fecal contamination of meat after slaughter contributes to the transmission process, and so improved hygiene in meat processing may be one further strategy that we can use to address this issue. I think it's fair to say that all of these strategies are a lot easier said than done, and all of them will require extensive collaboration with the relevant stakeholders. Just as an example, in 2011, the World Health Organization has published some strategies that can be used to reduce antimicrobial use in food-producing animals. And so some of these strategies are listed here, and unsurprisingly, you can see that promoting intersectoral collaboration is the first one. There's some others that I'm not really having time to go through at the moment. So in terms of the systematic review itself, I've learnt that they can actually be used for more than just comparing interventions, and in fact they can be used to address any question. And I've definitely used the skills that I've acquired from this research project to be able to construct such strategies at a relatively short period of time, and this has definitely come in useful for other projects that I've had in medical school. So I hope that I've been able to demonstrate an understanding of these two specific competency elements. Thank you for listening, and I'm happy to take any questions.
Questions?
Ben, I'm Bruce McLaren. I'm
Hi.
from Victoria. Great presentation, thank you. It's a touchy subject with agricultural organisations.
Yeah.
My previous experience, I think that's the biggest problem with this issue. I'm interested to know, and you may not know the answer, are third-generation cephalosporins in use in North America and Europe in agriculture? And do we know if they are in Australia? And if they're not, you know, is there a transmissible gene that may affect third-generation cephalosporins even if they're not being used in agriculture?
Those are all very good questions. So firstly, in North America, there is actually, so in Canada and the United States, there is actually, there's no current ban on the use of these third-generation cephalosporins. And the Food and Drug Administration there recently published a paper in Environmental Perspectives or something. It's a really famous public health journal, just advocating for the cessation of this kind of antibiotic use in food animals, because the World Health Organization considers 3GCs as one of the most important antibiotics for human health. And so this is one of those things that they can use other antibiotics, but using some health policy to limit the use in food animals is something that's a priority in those countries. In Europe, in some countries, there actually is, it actually kind of depends on which country in Europe. In the Netherlands, they do have some use of third-generation cephalosporins, and interestingly, in the Netherlands, they have a very low rate of antibiotic use in humans, but they have a very, like the highest rate of antibiotic use in food animals in Europe, and so that's possibly one of the reasons why all of those high-quality studies that found convincing evidence were all conducted in this country, because there's just so much drive of selecting resistance in animals compared to in humans. The specific genes that are involved in resistance, so there's kind of two main classes there's actually four, but there's two main classes for animal-associated bacteria, and those are the extended spectrum beta-lactamases and the AMP-C enzymes, which are kind of distinguished by their ability to, their response to beta-lactamase inhibitors. So in Europe, it seems like the extended spectrum beta-lactamase type are the more predominant ones that are associated with animals, whereas in North America, it's mostly the AMP-C enzymes. And this difference is also paralleled in humans and animal bacteria. So in Europe, it's mainly the ESBLs in both humans and animals, and in North America, it's mainly the CMY2 or the AMP-C enzymes in both humans and animals. Yeah.
Thank you very much. I'm just checking that all these strategies which you mentioned, I think it's there since 1950s, 1960s. So we know that there is a cross-resistant and utilizing antibiotic in animals to human and life. But what we can do about it, the strategies is there, but they are still using it, and they're still resistant bacteria transmitted to the human. So are we missing the target here, or do we need to do something differently, really?
Yeah, certainly. So I guess it's one of those things that is really quite, seems quite logical that selecting for resistant organisms in animals is kind of promoting the possible transmission to humans. But the evidence for this is not as clear as people would immediately think, especially for this particular type of resistance and this type of bacteria. But you're right in that it's been known for quite a while that food animals can harbour these resistant organisms which can be transmitted to humans. And they have actually tried to implement certain strategies. And I guess it's one of those things because it's for the agricultural industry, they basically just want to use the antibiotics because they believe that it would promote the growth of their product. And even though there's actually no evidence for that, but they think it would be beneficial for them. And it's kind of a bit of you have to a negotiating game with all these different parties. And I guess it's a little bit more complicated than would be just given from this presentation. And yeah, so like just this intersectoral approach is really quite important in addressing this issue. And yeah, one of the other things is to kind of, in terms of health promotion, another way of promoting it is to provide a supportive environment. And one of the other things that potentially, instead of like public policy to limit the use of this and say this is wrong, we could also try and provide an incentive kind of based measure. So not necessarily financial incentives, but there's recently, or there seems to be quite a big healthy food, organic food kind of culture at the moment. And if you could advertise, or if you could bring to the attention of these farmers that if you can advertise that your meat is antibiotic free, then it might just stimulate another different avenue of promoting health. Yeah. Yeah.
As far as I'm aware, the third generation kidney spawns probably aren't being used as general use in animals in Australia.
They're not, no.
So they're restricted, I think, to veterinarians prescribed by them.
That's right.
So I suppose, therefore, how would we run into problems in Australia if we're not having a widespread use of this antibiotic?
Yeah. Yeah, so that's a very good point, but I guess the problem is that we just haven't done any, or there haven't been any published studies in Australia on this topic yet. So it's not like, we don't know that there aren't any resistant, third-generation cephalosporin-resistant E. coli in animals, or in food-producing animals. They've done studies for companion animals, interestingly, like dogs and stuff, and they found that that is actually one of the sources, but there haven't been any in Australia for food-producing animals. And so I guess before dealing with that, it's kind of important to do the research. Interestingly, in 1999, I think the Department of Agriculture, Fisheries and Forestry, they established a joint committee and did a report on this exact issue, which is called the Jetacar, whatever. It's just a report on basically this exact topic. And it's encouragingly, they didn't find much forms of resistance in the animals and meat that they surveyed. But, and the most recent survey, I think, was in 2003 or 2004 or something like that. But this form of resistance has really kind of escalated really rapidly over the last decade. And so I guess it'd probably be worthwhile repeating or redoing these kind of studies to investigate that. And actually that's one of the focus of my experimental component of my honours project. Yeah.
Okay, one last question.
I've read studies previously about enterohemorrhagic E. coli and in the US and the importance of with cattle using corn-based feeds, which were cheaper and fattened the animal up more quickly, but tended to cause health problems and therefore require constant antibiotic use from the farmers. In this related area, is there any talk of the influence of corn, and is it potentially a strategy that could be used as in not using corn-based feeds and therefore not needing antibiotics?
Just let me think about that one. Yeah, so for most of the studies that I came across, or most of the studies that had evidence, they mostly sampled healthy food animals, so they didn't sample animals that were sick. So I think, and they didn't mention what kind of diet the animals were on, but I think the fact that they sampled the healthy animals is they're just trying to basically find the commensal isolates rather than necessarily isolates that have been selected by recent antibiotic use.
Okay, thank you.
Cool.
Okay, I'd like to invite Ms. Prashanti Manchikanti. She's a final year medical student from Monash University with a keen interest in global public health. And Prashanti has also completed a diploma in languages in French and a Bachelor of Medical Science through her studies at Monash University. Oh.
There we go. Excellent, thank you. So today I'd like to present the experiences of Afghani refugees accessing primary care in southeast Melbourne. And the aims of my presentation today will be to explore these issues of access within the context of the ethnic minority health competency of the public health medicine curriculum, which I'll demonstrate throughout my presentation. So this research commenced with a preliminary literature review and stakeholder consultation process to identify an appropriate research question and rationale for investigation in this region. So what did we know about refugee health in the area? Firstly, a refugee is anyone who has a well-founded fear of being persecuted and is consequently outside their country of nationality and due to fear is unable or unwilling to return. Of the over 700,000 refugees that have resettled in Australia since 1945, the Afghani population have consistently been one of the largest groups to arrive in the last 2 decades. This is especially seen in the Dandenong-KC region, where Afghani-born residents represent the largest and most rapidly growing regional refugee population. The inequitable complex health needs of refugees in Australia are compounded by by social determinants of health, including poor access to primary care. We know that primary care is cost-effective and health-enhancing, and therefore improving access to primary care for refugees may promote better health outcomes. For this research project, the concept of access was understood through the Pachansky and Thomas framework and includes 5 key dimensions, as can be seen here. The acceptability dimension focuses on the attitudes of refugees and their acceptance of the personal and practice characteristics of service providers and GP clinics, and include the age, gender, ethnicity and clinical practice routines of the GP and the neighbourhood and services provided by the clinic. We know that understanding the experiences of refugees is important to appropriately addressing their health inequities, but despite this, there is currently an evidence gap, specifically within this acceptability dimension. So in this context, we aimed to understand the acceptability of primary care services to Afghani refugees and to understand the relevance of the concept of acceptability to this population's overall access to primary care. In order to explore these aims, we conducted a qualitative community-based research study. Appointing and engaging a cultural advisor, an Afghani advisor, to this project was critical to this process, as the advisor was a former public health physician and refugee himself, and helped me to enter the world of Afghani refugees, understand their specific socio-economic health determinants, and identify appropriate recruitment and interview techniques. We recruited key informants and general participants to the project. Key informants were Afghani community or health leaders who represented the community and were recruited through publicly listed contact details. General participants were Dari or English-speaking refugees who had previously visited a primary care clinic and were recruited either through AIMS Settlement, the Peak Victorian Refugee Resettlement Service provider, local GPs, or through the cultural advisor to the project. The data were collected through 45 to 60-minute semi-structured interviews, and we worked with either the Dari interpreters or the cultural advisor for interviews that required interpreting. Data were then analysed through hand coding, and emergent themes were identified and framed against the 5 dimensions of access. So, what did we find? In this study, we recruited 16 general participants and 2 key informants. General participants were varied to age, ranging from 22 to 54, sex, year of arrival to Australia, and preferred language. Interestingly, the data highlighted 2 narratives, one of refugees who had arrived prior to 2008 and one of those refugees who had arrived between 2009 to 2011. These narratives underpinned the emergent themes that were found in the data and highlighted similarities and differences between established and recently arrived refugees. The findings highlighted that there are specific clinical routine features and personal characteristics of an acceptable GP that were valued by participants. Both established and recently arrived refugees described positive experiences with GPs that conducted physical examinations and provide patients with appropriate diagnosis and medication. Most female participants also valued seeing a female GP where possible. In addition, established refugee participants were also more specific about the prescription of medication, preferring medication to be prescribed upon first consultation. This was reinforced by participants indicating that they did not want to have to return, only to be prescribed medication at a subsequent appointment. Established refugees also spoke of the preference for GPs that were of Afghani ethnicity and fit within specific age brackets. These personal attributes were valued equally with the clinical routines of the GP. But in contrast, recently arrived refugees value the personal attributes of age and ethnicity of a GP less than the clinical routines of diagnostic skills and medication. As highlighted by one participant, "I don't have any preference in terms of ethnicity. They're all the same. To me, it's important they're a doctor, be it from any ethnicity or background." So specific features of acceptable primary care clinics that were common to both established and recently arrived populations were positive experiences of clinics that include a number of other health facilities. Specifically, pharmacy and diagnostic facilities were valued as the GP clinic acted as a one-stop shop for their healthcare needs. The impact of acceptability for access to primary care varied between established and recently arrived refugees. It was only established Afghani refugees that felt that acceptability would have a positive impact on their access to care, as they actively seek acceptable GPs and clinics and avoid previously experienced unacceptable primary care. For established refugees, acceptable GP would also have a positive impact on their health status, as they felt that the clinical routines of the GP would lead to better health outcomes. But in contrast, recently arrived refugees felt that the acceptability had a lesser impact on their access to primary care, as these participants felt that the personal and practice features of a GP was something that they could not control, as they had no choice in the matter. As one recently arrived participant describes, if a doctor treat me like that, badly, I don't have any choice except for coming back home. An interesting finding that emerged was the interaction between the acceptability dimension of access with the other components of the framework. Recently arrived refugees more strongly described that the geographical accessibility of the GP clinic, the availability of GPs and the length of clinic waiting time had a greater impact on their access to primary care. As some of the recently arrived participants said, distance is the only thing that can make it difficult or easy. So what does this all mean? Through this project, we have been able to clearly recognise that there are specific features of acceptability which interact with the other 4 dimensions for refugees' access to primary care. The findings indicate that the barriers within accessibility and organisation of services prevent access to primary care more than the acceptability barriers for these recently arrived refugees. One of the most interesting implications, perhaps, is the potential impact of acculturation, a length of resettlement period, on access to primary care. The 2 diverse narratives suggest that refugees' perspectives of access evolve over an increasing period since the initial resettlement, which may vary the way that services are delivered. So in line with these findings, there are implications for policymakers who may want to consider specific refugee recommendations to strengthen access to primary care, including co-location of pharmacy and diagnostic services within new and upcoming GP clinics, and recommending better hours of operation and appropriate geographical distributions of GP clinics to improve availability and accessibility. Similarly, GPs and refugee health program staff may consider the need to integrate multidisciplinary health services into their clinics to provide this one-stop shop for Afghani refugees. The negative attitudes that Afghani refugees express towards GPs that don't prescribe medication suggests that GPs should provide more comprehensive explanations when referral for diagnostic investigations and medications aren't indicated. This practice may be facilitated by improving existing health education programs for refugees to promote a better understanding of the Australian primary care system upon initial resettlement. And for future research, a number of questions emerged from these findings. Having largely missed the bulk of the Afghani refugee population aged 14 to 25, there's a need to understand the experiences of young Afghani refugees accessing primary care and any youth-specific values of acceptable primary care. And to better understand how the acculturation process affects access to primary care, it's worthwhile determining key factors during acculturation that shape refugees' attitudes towards primary care. So, upon personal reflection, participating in this research project as a student was an important learning activity. I've been involved in the process of identifying the health needs of a specific group within Australia and recognised challenges of working with a refugee population. Additionally, I was very fortunate to have been taught by refugees themselves, community representatives, policy gurus and practice stakeholders to understand the role of public health research to achieve greater health equity for vulnerable Australian populations. This research has actually greatly informed my future career trajectory and has led to subsequent public health opportunities. And I'd like to actually use this time now to make a brief appeal to all physicians to engage students in their public health research, because it's been very personally and professionally rewarding, and I strongly believe will make students better doctors in whatever their chosen field. In conclusion, I hope that the findings will suggest pathways for primary care policy and practice and will become part of a spectrum of activities to improve health outcomes of a population facing growth, health inequities in our country. And I'd just like to finish by acknowledging a number of people for their role in this research, and I hope that you've learned a little bit more about the ethnic minority health competency through my presentation. Thank you.
Have any questions? Yeah, Rosemary.
Prashanti, that was a dazzling presentation, because not only what you talked about, but your use of technology. I think all of us are quite envious of the way you did that, and we might talk about that afterwards. So thanks for that. I'm particularly impressed with asking these questions about particularly vulnerable Australians. And I'll ask you to comment on, first of all, whether or not your colleague medical students have access to this kind of research opportunity as well, or was it just because you sought it out and sought the way of finding it, or is this something that you find is widely offered in your institution?
Sure, thank you for the question. I can talk initially about how I've sought out the research and perhaps then reflect on Australian medical students as a whole. I think these opportunities are actually quite readily available. When I was looking for a bit of research to do for my research report as part of my medical curriculum, I emailed a number of different groups of people, some relating to vulnerable populations and some sort of more related to policy research as well. And I think that a lot of researchers are quite keen to get students involved, which was really pleasing. I also have been quite involved with our global health group at our university, which often attracts a lot of students that are interested in public health and public health research. As a whole, I think Australian medical students are quite fortunate that we are able to have these opportunities available. Perhaps they're not marketed as well as they could be, though. I know that from this research, I spoke to my supervisors about encouraging them to attend some of the research presentation sessions for students so that they can attract more students to their unit. But there are opportunities available. I think that they could be perhaps more well known amongst students. I know that during BMed Sci opportunities as well, there's a lot of sessions for students to get involved. I think that working with vulnerable populations has been something that some students are quite interested in, but it can deter others. It was quite nerve-wracking for me to work directly with refugees, particularly as I felt at that time of doing research I had very little to offer them directly in terms of services. This was especially with the recently arrived refugees who arrived within the last 2 to 3 years. You know, during interviews, they would start talking about other difficulties that they were facing, the competing settlement priorities such as housing and employment. And I personally felt that was quite difficult for me to take on, and I was fortunate that my supervisors were enabling me to do a lot of debriefing with them after each interview. So, yeah. But as I sort of said in the presentation as well, I think there's lots of research out there and students are really keen, so if physicians are able to engage them, would be very welcome for the opportunities.
Thank you. Just a question. If we surveyed the general public about the primary care, they want something closer, no waiting time, and one stop. So what's the difference between the Afghanis and the general public?
Yeah, that's something that we considered quite a bit whilst I was writing my report, actually. What's the difference and how is this really different to other populations? I agree that a lot of the literature that we saw in comparing this population with the wider Australian population, they wanted GP clinics that were more accessible and had reduced waiting time. However, the difference we found particularly related to the acceptability dimension, which was the initial focus of this research, and that there was this clear shift in narrative where the recently arrived refugees didn't actually care so much because they felt that they had no choice in the matter. They weren't as concerned by the GP's actual ethnicity, age, sex, all those sorts of factors, whereas those that had been in Australia, had resettled for a longer period of time, were more interested in finding a GP that was more appropriately matched to their preferences. And we found that was probably the more interesting component because it actually reflected how the local population of that area who had already had some research done, they all wanted GPs that fit within their specific preferences of age, gender and ethnicity. Which suggests that perhaps through an acculturation process, refugees may take on these values of finding out that they can request specific GPs or they can seek out specific GPs. Perhaps more in the other dimensions such as accessibility and accommodation, which is the organisation of services, there isn't necessarily as gross a difference between refugees and non-refugees within the Dandenong KC region. But there are barriers that recently arrived refugees in particular do have to try and overcome to find a GP that is close to them, and to find a GP that won't make them wait a long time. I mean, I'm aware that this can be provocative in some sense, because there are a lot of pressures on GPs and on primary care clinics as well, to try and meet these demands. Yeah.
I might just limit the questions, because I realise that if we let Kate have her 10 minutes and 5 minutes questions, we're going to be at 12:30, and then the judges need to have some time to make their decision. So thank you very much. Our final speaker is Dr. Katherine Hooper. Katherine graduated in 2012 from the University of Notre Dame in Fremantle with honours. She's currently working as an intern in Fremantle Hospital, and she's looking forward to living and working in Broome from August onwards.
Yes, very lucky. Thank you for having me this afternoon. I'm going to talk quite quickly on the audit I did as a final year medical student, and then on a reflection and how it relates to the faculty's competencies. So just as a bit of a background, pertussis infection, or whooping cough as it's commonly known, is caused by the gram-negative bacilli Bordetella pertussis, and it's highly infectious and transmitted via airborne droplets. And it can be a devastating illness in infants under the age of 12 months. And it's really reflected in the sobering statistic that 1 in every 200 infants under the age of 6 months who are infected with pertussis will die. Fortunately, though, it's a vaccine-preventable illness, and it is recommended as part of the routine childhood immunisation schedule, and in Australia it's funded under the Immunise Australia program. So because of the risk of infant pertussis and the fact that immunity to pertussis wanes after 6 to 10 years, there's a recommendation for an adult booster of the formulation for any adults planning a pregnancy or parents soon after the birth of a new child, or any carers. And this is on the back of several studies that have identified parents as the main source of infection for pertussis in young infants. And this kind of idea of immunising people around young infants is often referred to as the cocoon strategy. So just a bit of a context, in Australia there's previously been an epidemic in pertussis, and this is some data from Western Australia that shows the notifications peaking between 2011 and 2012. And as you can see here, non-immune infants, those aged 0 to 4 months, so before they get the second dose of their vaccinations, account for a considerable burden of the disease. And so because of this, between January 2011 and December 2012, the WA Department of Health funded a free booster vaccination for new parents and carers, and it was available from maternity hospitals and participating community immunisation practices, as well as GPs. So what I looked at, I did an audit at an outer metropolitan hospital looking at the uptake of this pertussis booster vaccination, and so the aim was to establish that it was being offered to all new mothers, and our standard was that it should be offered to 100% of new mothers. And what we did is there were 1,372 deliveries across the 12-month period from January 2011 to December 2011. We randomised records, and we ended up with about 80 records to audit from across that 12-month period, and that accounted for just over 5% of deliveries at that hospital. And I'll just go quickly onto our findings. So actually, I'll go back for a second. The other thing that we did in data collection is we mainly looked at whether they'd received the vaccination from the medication record, just to see that it was given. But we also looked to the STORK database, which is a record that midwives enter key indicators of ante, intra and postpartum care. So this is things like method of delivery, date of delivery, any complications, whether vitamin K was given to the infant, or whether they received neonatal hepatitis B. And recording the booster vaccination has been an optional component of the STORK database since January 2011. So we wanted to try to validate that at least as a secondary data source, with the idea that we could then look across all deliveries in that 12-month period at that hospital and get some really good ideas about who was taking up the vaccination. So what we found is that 60% of the cases that we audited, women had received the booster vaccination. And what we found was 50% of the time this was documented in the stalk database. We never found that it was incorrectly documented as given when it wasn't, but it was just that it was a bit of a 50-50 thing of whether someone inputted it in the database to say it had been received. And so that 50% was a little bit disappointing because we know from previous audits of things like neonatal hepatitis B in the stalk database that it tends to be an accurate reflection of what's actually done. But those are compulsory elements within that database. And in terms of 60% being received, well, it was quite difficult to interpret how well that related to anything else. And this is something I really learnt in my undertaking this audit about public health and how we look at vaccination surveillance. So there's been a lot in the media in WA and Australia in the last month or two, particularly around the National Health Performance Authority's release of the 2011-2012 immunisation statistics in Australia. And the reason that we get such great data out of that is because of the Australian Childhood Immunisation Registry, which is reported to account for 99% of children in this country. And I'd had no appreciation before doing this audit and looking at this thing that in adults, the only registry we really have for vaccination is HPV. So outside of that, all the information we get on vaccination rates is by telephone surveys. So we didn't have a lot to compare pertussis to. And that brings me to reflect about surveillance, which, I mean, this is a definition from the World Health Organization, but essentially when we get meaningful data, we can make meaningful intervention and we can really evaluate the services that we're putting in place. And that relates to this competency. And so what I was not just analysing surveillance data to support prevention and control of infectious disease, I was actually trying to establish whether we could get some surveillance data out of the stalk database itself, which proved to be a little bit difficult. And I guess you can say the ship on pertussis booster vaccination has sailed in a way, because while it's still recommended, it's no longer funded as a free vaccination in WA. But this conference here is all about future directions. And so it's really about what we can use with this information. And the biggest thing that has an impact on is antenatal influenza vaccination, which is, we know is can prevent serious cases of infection. For every 5 women that you immunise, you prevent 1 serious case of neonatal or maternal respiratory tract infection. And for every 1,000 women that you immunise in the 2nd or 3rd trimester, you prevent 1 to 2 hospitalisations. So this is currently funded free for antenatal vaccination. They're considered to be medically at risk group. And at the moment, its documentation in the stalk database is an optional component as well, just like pertussis, which we've shown doesn't give us a great reflection of actually what's happening if we look at the information in the database. So this brings me to the other competency of advocacy. And when I was initially looking at pertussis, I was thinking about it's really important to educate midwives who are rolling out the vaccination on the ground about why it's important, and that was, you know, influencing clinical staff to adopt a population health approach. But what I'm also learning a lot about through this process is that it's about promoting a population health within the health sector itself. So it's about convincing people like the committees that oversee the stalk database that this is an important thing to monitor this as a source of surveillance. And it's a real difficulty, and it's still an optional component, but it's not something that we shouldn't keep trying to do. And this is kind of reflected in the last week with the WA immunisation strategy for 2013 and 2015 came out, and they've got 12 objectives in that. And objective 6 is about increasing adult immunisation rates in those medically at risk, and specifically antenatal influenza is highlighted there. And they have an objective 9, which is about increasing surveillance of vaccinations. And they talk about utilising existing data sources. And so this is a perfect example of how we could do that. But what I'm learning in this audit and the process of reflecting on this all is that it's actually quite a challenge to get people outside of your little patch to think what you do is important as well, not just the outcomes that they're looking for in their own database necessarily. So I'd like to acknowledge the following people who were really instrumental in teaching me about auditing in general and the conceptual involvement in terms of designing this. And there's some references. So thanks.
Any questions?
So what do you think are the barriers to better recording of these immunisations in this book database?
I think with I think pertussis is quite difficult. One of the barriers when I was looking at that as a whole is that you're actually kind of asking for an intervention in the obstetric setting that has a paediatric outcome. So ownership of that issue is key. And the reason I actually wanted to do this audit is when I was a student on my obstetric rotation about 2 years ago, I would see, you'd go around on ward rounds and they say, Dona, do you want the booster vaccination? And mum would say something like, no, I want my baby to have a strong immune system. And that would be the end of the discussion. And so that was really frustrating. But I don't think obstetricians really saw it as their thing that they had to deal with. And paediatricians rarely see a mum unless, you know, something's wrong with the baby in these kind of settings. So that's a real barrier in terms of the ownership of the issue on the actual ground. And it's the barriers as well is that midwives, they're great at entering data in the STORK database. We know that they can do it well when it's required of them, but they also don't enjoy being off the clinical floor because most of them didn't go into midwifery to enter data into a database. They did it because they wanted to deal with mums and bubs. So convincing those kind of people that ticking, you know, putting something in a box is going to help us understand who's getting these vaccinations and where it's working and why, and that we can better resource this, and this has better outcomes for their patients in months and years to come because they have, you know, higher birth weight babies and less risk of preterm delivery is really important. But, you know, everyone's got their little patch and they do need to protect it in a sense. But, yeah, it's a real challenge, I think.
Yeah, no, we had another question. Yep.
Thanks. It's more of a comment than a question, but I'm Kristen Pearson, a geriatrician from Melbourne, and I personally had pertussis in 2009, and I can absolutely not recommend it. And I had 5 weeks off work, which I've never done before. Wow. So I guess my comment relates to some of that monitoring and the case for actually having vaccination. So I personally think, you know, it's not something I'd wish on my worst enemy. I certainly thought I was going to die waking up with laryngospasm in the middle of the night. Oh. It made me wonder how often I've missed the diagnosis in my own patients. You know, it's hard to diagnose. You see them during the day and your chest sounds good and there's nothing to see, and then at night you're terrible. And, you know, I wonder how many times I've missed it in my own patients. You know, you do wonder not only what morbidity, but perhaps what mortality it has, particularly in elderly patients. And as you say, if we don't have good, robust monitoring systems around this and good vaccination programs around it, I rang my work and I said, look, I might have had pertussis for a few days before I realised, and I might have infected some of my patients. They said, well, do you work with babies? I said, no. They said, well, we don't care, we're not interested. And then I said, well, maybe we should be offering vaccine. I had 5 weeks off work. What sort of occupational, you know, implications are there? And, you know, I didn't really get any traction there. And as you say, if we don't monitor, if we can't find it and if we can't monitor it, we don't have a case for vaccinating people. And I certainly told all my friends, you know, everyone I could talk to, get vaccinated. It's not good. So that's just my comment.
We're quite lucky here. I think when I was starting work this year, we were all offered the booster vaccination as healthcare workers. But I think that's us in our little area. Yes, Ben.
You mentioned some data about for influenza vaccines that there's a number needed to treat of 2, I think, to prevent a serious.
So for every 5 immunisations, you prevent a serious.
Do you have similar kind of data on the pertussis vaccination? Like, how effective is it at preventing those kind of things?
The evidence for pertussis actually isn't as strong as it is for antenatal influenza, and that's one of the reasons that it's not really funded in the same way that it used to be. I think the Pharmaceutical Benefits Advisory Committee in 2011 ruled that it was pretty cost ineffective, and the evidence behind it was a little bit more shaky. It's quite hard to get evidence for pertussis. There's no randomised controlled trials or anything like that. But we've certainly got much more evidence behind antenatal influenza, and it's something very strongly endorsed by the Royal Australian and New Zealand College of Obstetricians and Gynaecologists for their patients.
Yeah, Charles, you had a question?
So, did I miss this, but what is the current recommendation for teenagers and adults in the new immunisation schedule?
In regards to pertussis?
Yep.
So it's still recommended for adults planning a pregnancy and soon after the birth of their child, but it's no longer funded for free in WA. I think in New South Wales they still are funding it in some maternity settings, but mostly around the country there were similar schemes where it was free, and it's all been rolled back in the last year or so.
Yeah. And you mentioned the cocoon approach. So would you making recommendations for grandparents, and it's because what would your perception be of whether or not grandparents, for example, understand the risks that they might have in caring for babies, given the emphasis on mothers and babies?
Yeah, I mean, it was definitely recommended, and I think they could access the vaccination for free as well as carers of newborns. But unless it was specifically kind of mentioned to them and they came into contact within the healthcare service and mentioned that they were a carer, I doubt that they were ever really offered or educated anything around that. So it probably would have been, you know, a matter of the mother being educated about it in her time in hospital when she was offered the booster and being able to pass that on, that other carers should have that. But I think, you know, this was, you know, something that was done to try to contain the outbreak and protect those most vulnerable, and there's not necessarily a lot of resources to roll out a huge community awareness campaign about these kind of things. But we're lucky, it got a lot of traction in social media. I think even today, this morning, when I looked at my news feed, one of the girls I went to school with who's just had a baby was posting all these stories about pertussis, and there's, you know, you can get information out there, but we can look at ways to kind of resource that a bit better, particularly if we've got good surveillance data from these kind of existing data sources where you can say, you know, this area is performing really well, and these are the demographics of the people that are taking up this vaccination, and this is the demographics of those that aren't, and whether you can put in some key bits of information, things like social media, in those areas that give you quite a high yield for the resources that you put in terms of education.
Okay, you haven't asked a question.
Okay.
Yeah.
Hi, thanks, Katherine. Fantastic. Can you give any comment, just stepping back a little bit, about how confident you are that your sample of 80 represents the wider cohort that would be delivered?
Within that, yeah, I mean, if you looked at statistically significant sampling, you'd have to take about 300 records from the almost 1,400 deliveries over that year. But I guess the process of auditing is really just having a snapshot and seeing, like, is it done or is it not in these records? And you just have to kind of have faith that that represents what's happening in that service. And the midwives that we spoke to weren't surprised by 60%. They thought they were offering it to everyone, but they thought 60% sounded about right of the women that were actually taking it up. But it really speaks to the need to have, you've got this great database, it's an optional thing. If it was compulsory, if it was done well, and you could validate it as a secondary data source, you could look at all of these records and you could say that it reflects what was happening across the health service, and then compare health services.
Okay, last question.
Just a commentary, we don't have strong evidence that cocoon vaccination is working. That's the problem.
Yes.
That's why most of the ministries of health everywhere, they advise people to get the vaccination, but they've never funded it.
Yes.
So that's the reason.
Yeah, but it doesn't say that when we roll out something, that we shouldn't be able to look at it fully and have surveillance measures about how well it's working and being able to evaluate the service that we've rolled out. I think that's still important.
Okay, thank you very much.
Thank you.
Okay, so I'll invite Paul, you're going to come and do the honours.
Hi everybody, kia ora. Greetings from New Zealand. For those who don't know me, I'm Paul Bohmer. I'm a public health physician working in the planning and funding team, Auckland District Hospital in Auckland. Thank you to the faculty for the John Snow Scholarship. I think it's a great opportunity for the medical students, and for those who don't know, it has been agreed by Council to roll out the scholarship to New Zealand medical students as well. So hopefully that next year there'll be a New Zealander to put the cat amongst your Australian pigeons. And I think, you know, it's a fantastic opportunity for medical students to be able to participate in the John Snow Scholarship, so I hope to see it grow and continue. Very hard decision for us, and I'd like to thank my fellow judge. We had some robust discussion, but at the end of the day there can only be one winner, and we've decided to award that honour to Katherine today. So well done, Katherine, and well done to all the other participants.